fall. We are fortunate and lucky to have both Dr. Karen Schultz and Dr. Cherie Hiscock with us today, talking to us about the hidden curriculum and its impact. Our speaker, Dr. Karen Schultz, is a professor of family medicine, School of Medicine, is an associate dean, postgraduate medical education, School of Medicine at Queen's University. She has a prolific career as an educator and a mentor, and is widely known and recognized for her leadership in implementing competency-based medical education in the family medicine program. She has been the recipient of numerous awards that celebrate her work, both as administrator and as an educator. One program director at the Queen's Department of Family Medicine. She received the Payroll Program Award of the Year in 2012 and 2016. She's a 5-time recipient of the Clinical Instructors Award, a 3-time recipient of the IG Excellence in Clinical Teaching Recognition Award, and a 2-time recipient of the Faculty of Health Sciences Education Award. I can tell you I had to trim this down a lot. She has also received the CAM Best Poster Award, the Family Medicine Residents Appreciation Award, and was recognized by the Office of Faculty Development Professional Enhancement Recognition Program. The focus of Dr. Schultz's research is on medical education. Through her scholarly work, she aims to improve curriculum, assessments, and learning outcomes for medical students, residents, and fellows. Her recent research projects cover topics such as transforming the assessment culture, incorporating leadership development in family medicine, residency, and establishing curriculum learning outcomes for leadership skills development. Also, our speaker, Dr. Cherie Hiscock, is an associate professor, Department of Psychiatry, School of Medicine, Assistant Dean, Academic Affairs and Programmatic Quality Assurance, Queen's University. Dr. Cherie is a child and adolescent psychiatrist with a special interest and expertise in the diagnosis and treatment of psychiatric disorders in people with intellectual disabilities. She has provided services in the Division of Child and Adolescent Psychiatry and the Division of Developmental Disabilities at Queen's University. Outside of clinical activities, Dr. Jones contributes to the undergraduate medical education program at Queen's University School of Medicine regularly and holds key leadership positions as the Director of Clinical Skills and the Academic Lead for the Communicator Competency Curriculum. So we're looking forward to a very engaging discussion on the hidden curriculum and its impact.
Thank you so much. And welcome to everybody who's zooming in. It's nice to have you all here with us. Thank you for that lovely introduction. That was very kind. For the purposes of this talk, one of the other things that Cherie and I did was we co-chaired the working group that looked at the hidden curriculum here at Queen's, and we now have an implementation group that I'm chairing. So I'll let Cherie Cherie, did you want to add anything while I load up our slides?
No, I think that some people would probably know that the working group that Pinky and I co-chaired was as a result of a comment that a faculty member had made to medical students. It feels like just a couple of years ago with COVID. It probably, if you count it, it actually goes back about 6 or 7 years. And the working group was actually struck by Dr. Rich Resnick, who was dean at the time, and wanted to look into the state of the hidden curriculum at Queen's in particular. And the implementation committee actually started its work about 2 years ago, is still going on. We're always looking for people who want to join and be part of that, but we're looking at trying to really move the recommendations of the report that we put together forward, both in UGME, PGME, even within CMO and QHS in the hospitals. So if anybody's interested in that, just reach out to myself and Pinky. We'd be happy to share and happy to have you join if you have an interest.
Perfect. All right. So just to start out, we did want to actually let me get rid of this. We did, oh, that's still not working. I just don't want to block your slides. See what I'm doing. It's on that one. Okay. Thanks. No problem. I think the rest of it. Oh, okay. Oh, that's great then. Okay. Yeah, and then we'll get it out for the people on the room. Perfect. Okay. So Cherie and I are not making massive amounts of money off of it. In fact, we're making no money off this work. So we have nothing of financial concern. But I think in thinking about our own biases, implicit biases, as you heard, I'm a family physician. I went to medical school here at Queen's. I did my residency here at Queen's, moved away for a bit and came back and have basically my whole working career has been here at Queen's. And Queen's has offered me so many opportunities and advantages. I'm a Queen's fan, but I have absolutely faced the hidden curriculum throughout all stages of my career here. So I come with those biases into this work. And Cherie, do you want to talk at all?
So I did not do my studies here at Queen's. I did most of them at Memorial, but I can say absolutely the same thing as Pinky, that I've actually experienced the hidden curriculum at all levels of not just my career and work, but also as a student. I actually matched to a specialty and then changed in my second year to psychiatry. And that brought out an awful lot of comments as well for hidden curriculum. So it's alive and well. It's across the country. This is not unique to Queen's. But Pinky will explain why we limited our work and our study to Queen's to start with.
Okay. So all right. So just very few objectives. We want to talk to you about what we found out about the hidden curriculum here at Queen's within our School of Medicine. But then we also want to have some discussion at the end around ways to positively impact the hidden curriculum, particularly at a personal level, which is what you can control. So to start, there is going to be a couple of polls throughout this. So for those in the physical audience, if you want to grab your phone, for those of you online, you're going to be able to access this through either opening up a new browser or using the QR code. So you can either get into slido.com and put this event number in, or just scan in that QR code. And this is going to be on the next slide as well. So if you didn't get it on this, not to worry. So I first just want to check and see if you know, I want us to be on the same page when we think about what we're talking about. So everybody, it's interesting, people have different definitions of the hidden curriculum. Do you understand what we mean when we talk about the hidden curriculum? And I will tell you, the audience is almost always very split on these answers. So that it's always good to see the polls start working, that you know that people are getting on that. And I think we have about 25 or so in the audience at this point. 28. Okay. I'll just watch that participant number up at the top of my screen. Okay. There's going to be some more polls with exactly the same way into the poll later. So if you didn't get in this time, you'll be able to next time. So really common, you know, we start in medical education, we start using this word hidden curriculum a lot. And some people say, well, I'm not really sure what you mean. So just to be really clear, the definition that our working group used and our implementation group is the hidden curriculum is all about implicit messages. It's all about what you gather. It's not those explicit stated things. Those may be intended, they're often unintended. They may be positive, they may actually support what a formal curriculum is teaching, but we often tend to think of the hidden curriculum when it's negative, when it undermines, but it can be positive. And it's about the values, norms, and attitudes that are inferred from peoples and institutions, both actions and inactions. So we're thinking about those implicit messages. And to be really clear, the hidden curriculum can be felt at a whole bunch of different, in a whole bunch of different realms. It can be felt at, you know, gender, race, between the physician-patient, lots of different realms, but we really confined our study looking at the professional interactions between those in different areas of medicine. So that's what we're going to tell you about today. This is what we value. When we look at our formal, institutional, declared values of how we expect people to interact, so through the strategic plans, we value diversity, we value respect, we value collegiality. That's the institution we want to be. But when we did this work, we found a lot of evidence of that not being what's playing out. So this is a quote from a medical student from our study who says, "I can't tell you how disappointing it is to hear the disrespect attendings and residents have for their colleagues. I thought medical doctors would be better human beings." And if we think, what are our aims as a teaching institution? We basically have two things we need to do well. We need to provide an optimal learning environment for our trainees and provide a wide variety of options for them. And we need to provide excellent care. And if we think about the quadruple aim, that's that idea of improving patient outcomes, improving the patient experience, trying to reduce cost, and having a highly functioning healthcare team. And what we found with our study is the negative hidden curriculum is undermining both of these two main things that we do as a teaching institution. So what this next hour or 50 minutes at this point, we'll tell you a little bit about our study. We'll give you a high overview of the results of that and the impacts of that. And then we'll switch into some ideas for solutions so you feel you've got something that you can take away and do after today's talk. So we're going to tell you some ideas for solutions, but we're also going to leave some time at the end because these presentations to departments have been really fabulous for also getting other people's ideas about ways we should move forward on this. So let me just tell you about the study. As Cherie mentioned, it was quite bounded. So although there are 17 schools of medicine, we only looked at Queen's, although certainly anecdotally heard from across the country that this is not unique to Queen's. This is a pretty widespread phenomenon. And although we have 3 schools within Queen's Health Sciences, we only looked within the School of Medicine. And as I mentioned, lots of ways to look at the hidden curriculum, but we looked at this one particular aspect of those interprofessional interactions between those different disciplines. We had our working group, and our working group was very deliberately brought in broad, invested peoples in this topic. So we had medical students, residents, and faculty. Our faculty ranged from primarily mid to later career faculty, but from internal medicine, family medicine, psychiatry, surgery, and critical care. And then Chris Gillies was on this team as well to bring the hospital perspective into our group. We did a really thorough literature search. We just wanted to find a survey to say, well, let's find out what's happening at Queen's. There was no survey. So we created one based on the literature, and we gave it to our medical students, residents, and faculty. And for those of you who filled this out, which would maybe have been about 3 years ago and a lot of pestering from us, thank you for that. We had about 140 to 160 respondents in each of those 3 groups. We explored this widely. So we looked for evidence of positive hidden curriculum as well as negative. We tried to look for it at the personal or micro level, the institutional meso level, and the bigger organizational macro level. We looked for expressions of it, where it was happening, what people's personal actions were around it, how it was impacting them, and then their ideas about why is it here and what might be some solutions. And then with the help of OpDes, we analyzed the results, doing a quantitative analysis of the Likert scale questions and a qualitative analysis of all of the comments that people had the opportunity to write after every question. So here's a broad overview of the results. So really nicely, you can see, so blue is medical students, orange is residents, and gray is faculty. You can see that people are hearing positive comments. They are hearing examples of a positive hidden curriculum. But you'll also see that there's not an insignificant number of negative comments. Somewhere between 15 and 20% are hearing negative comments. And like with the usual negativity bias, people remember the negative stuff more than the positive stuff. So these are some comments that talk about how sticky those negative comments are. It's those negative comments that stick with you. It's hard to remember specific examples of respect, but really easy to remember episodes of disrespect. So many examples of physicians who are respectful, but it's the few that aren't that undermine our culture. And to be really clear, this is affecting across a broad swath of everybody within our medical school. It impacts in the majority of areas of medicine. It is impacting people at all ages and all stages of their career. There is some intersectionality, and by that I mean some people are more affected than others. So our young female, both students and faculty who are in generalist areas of medicine are more impacted, but it's really important to be clear, this is across the institution. And even within departments with divisions, it runs through divisions as well. So these are the most negatively targeted areas: emergency, family medicine, pathology, and for those of you in the room, the last two are psychiatry and surgery. But I do really want to make that point. It is being very broadly felt. And it's negatively impacting in many, many different ways. So for our learners, it's impacting their opportunities. People are hiding their career choice as medical students, or when it becomes obvious, they sometimes are limited in the opportunities they've been given. For people who've chosen their career, it's limiting their, for our medical students, it's not providing a level playing field of what are regarded areas of medicine to go into and what aren't. And so they come into their CARMS match with this idea of there's a better and there's a worse way to go forward in your medical career. It's impacting career satisfaction. For our faculty, the perception it's impacting their opportunities to progress through the academic milieu. Definitely the feeling it's impacting patient care, probably a lot by decreasing healthcare team morale, and that this is a generational cycle. So I think I saw before we flipped over, and I could see that Mike Brundage is on the call. Mike and I went to medical school together in the 80s. The comments I heard in the 80s were the comments I heard as a program director, are the comments I'm hearing from the residents across all of the programs now. The same kind of comments, this generational, just soaking in of what's okay to say and what's not, and just keeping it going. And again, thinking about these two things that we do as a teaching institution, here's some quotes to talk about some of these impacts. So on our learners, they're hearing really negative things about certain specialties, and it makes a really toxic environment when you're trying to decide what career to pursue. They keep hidden what area of medicine they're interested in so they don't lose out on opportunities. And when they had chosen, it made them resent that choice because it was this feeling that they're thinking of going into a lesser area and that they just weren't good enough to go into another area of medicine. On healthcare, it creates artificial barriers and a negative working environment, especially those transitions of care where patients are crossing from a generalist area to a specialist area. That's where a lot of this overtly plays out, and that it's contributing to burnout, which ultimately impacts patient care. So having widespread impacts. So it's a culture shift. It's going to be a culture shift, which is never easy. So what do we do? Well, first we have to understand, why is it here? So when we ask people that, why do you think we have this? Some of them talked about role modeling. It's that generational perpetuation. I saw it, I just kind of soaked that in. It just became a part of the way I thought about things, and I just kept going with it. Some feel there truly is a bias. Some people truly believe some areas of medicine are better than others. Although if we put the patient in the middle, the patient needs all of us doing our job well. But there are visible disparities of who are in power positions, who sits on those power committees and makes decisions. That when people are repeatedly behaving disrespectfully, they're not held to be accountable for those actions, and there's no intervention to change that. So I'm feeling that it's human nature that we need to feel part of a team, which I think we do for the most part, feel more comfortable when we feel part of a team. But why that devolves into an us versus them, a better, a worse, a need for hierarchy is just a really interesting thing to think about. That we're exhausted and we're overworked and we're burnt out, and it's hard to be our best person when we're kind of stressed ourselves. This feeling that some areas of medicine truly do provide poor patient care. And so if you believe that, you can see how disrespect might evolve from that. This age-old thing of equating pay with value. You're paid more, you're more valuable than the person who's paid less, and that's an organizational thing to think about. Why is our fee structure the way it is? And there's a lot of conversation we could have about that. That we don't understand each other's work. We work in silos. We don't see how each of us contributes to patient care, and how do we break those down? And then this, again, intersectionality coming into play, that where an area of medicine is seen as predominantly female physicians in that area of medicine, that's a lesser area of medicine. And some really interesting studies to back that up. So lots of potential causes. It's clear this is not a simple one cause, one solution kind of thing. This is one of these so-called wicked problems. And so how are we going to go about doing that? So switching over to thinking about what the implementation team is thinking about and how we're going to go about addressing it. It's clear we all need to be part of the solution, everybody within our organization, that we want to think about it at that personal, institutional, organizational levels. And where we see it's being done well, we want to celebrate it. Those positive things, those people who are acting to support our values of diversity and inclusivity and respect, we want to grab those examples and we want to celebrate them. Our feeling is truly that the vast majority of people working at our institution are well-meaning. They don't mean to undermine and be disrespectful. It's stuff they've soaked in. And so for that, it's just some educating of, you know, when you say this, this is the impact it's having. Here's a different way of doing it. And I'll give you some examples of that. Where that doesn't work, that there's a more intensive remediation for people who perpetuate that disrespect. And where that doesn't work, we have to put a structure in place where people are held accountable. And there's consequences for ongoing actions that undermine our value. So Cherie and I are going to switch over now and really focus on the micro, because you can hear stuff like this and you think, oh my God, like that's huge. What can I do? I'm one person in this big organization. What can I do? There are many things you can do. And your influence at a personal level is first realizing just how influential you are in all kinds of different ways. So here are some quotes from medical students, faculty, residents around the impact of role modeling. The things that you don't even think are being soaked in, but you know, those jokes, people like them, they laugh at them, but when they have an undertone of disrespect, which they often do, that has lasting influence. That it really does shape that personal identity of what people feel it means to be a physician. And then this is the last quote is these negative attitudes. You also become part of this generational perpetuation if you don't mindfully think about how you go about doing things and just keep going in the same old way, that it becomes a self-perpetuating problem where biases are passed on to junior learners who then become seniors and then they continue to pass it on. So lots of personal impact. So you have influence in two ways. You have influence in how you personally behave. And you have influence when something happens and you're there, and what do you do about it when you see it? So I'm going to talk a little bit about personal behaviors and then turn it over to Cherie to talk about allyship. So these are not hidden. These are direct quotes of what the medical students have heard through their time here at Queen's. And I'll just let you read these because I think these are over. This is absolute disrespect. There's nothing left to the imagination about this. And these, in fact, are probably easier to deal with because they're obvious. But a lot of what's happening are those so-called micro invalidations, micro disrespect. And these are harder because you're not quite sure what does that mean? You just walk away with a little bit of a sense of unease. It's kind of hard to react in the moment because it's not clear in the moment. Or if you do react, it seems like you're taking a molehill and blowing it up into a mountain. And what's the matter with you? Can't you have a little bit of humor? All that kind of stuff. So this, you're too smart for, and literally in that XXX, put in any specialty you want. We read this quote throughout the whole study. I certainly heard it when I mentioned my intention of going into family medicine. You're too smart for family medicine. You're too smart for oncology. You're too smart for psychiatry. You're too smart for surgery. You're too smart, literally put anything in there. People telling people, I'm not sure, just because, you're nice, maybe you should not think of doing this and you should think of doing this. Lots of examples of this. So I want to unpack this a little bit because I think we all do this sometimes, and we're not meaning to be disrespectful. We have another intention behind what we're doing. So I'm going to ask you, what do you think when someone says you're too smart to do oncology? What do you think people mean by that? Yeah. Which it shouldn't be, right? Yeah. Maybe 70%. We'll say it's at 70%. Okay. So the 100% wouldn't be right, but the majority feeling, well, they think this is truly a lesser area of medicine. That's a whole different education. That's a whole, our patients need all of us doing our job well. We're all important in the patient's journey. But a lot of these are meant in a positive way. They mean it as a compliment. You're really smart. And then you just don't need the end of that sentence. Or they really like this medical student and they would love them to come into their area of medicine. So I think if you catch yourself doing things like this, it's really important to try and parse out, and this comes from conflict resolution approaches, where your intention and your outcome don't match, is really exploring the action in between. So if your intention with you're too smart to be an oncologist is you're really meaning to compliment this medical student, and your action is to say you're too smart to be an oncologist, realizing the outcome on that learner who's chosen to do oncology, that they recognize it as a backhanded compliment, but if they're interested in that specialty, it undermines their sense of value of that specialty. So it's not having the outcome you're intending. And so instead, just say exactly what you mean. If it's meant to be a compliment, you're a great medical student. I think you're doing a fabulous job. You can do well in whatever your area of medicine you want to go into. Or if you're trying to influence them and you want them to come into their area of medicine, can I tell you about our specialty? Do you think that would be something you might be interested in? You don't have to undermine another specialty to promote your own. And if you're thinking, oh my God, I know this area of medicine, I know how tough it is, I want to be able to have that conversation about, here's the positives of this, but here are the things that you're going to face with it. Just have that conversation without undermining something else. So these are things on those educational fronts that I think well-meaning people can start to explore what they're doing. I'm going to turn it over to Cherie now for the last part of our session. I'm going to end with this is the last poll, because I think it'll help set up what Cherie is talking about. And I'll just stop at the end of this poll to see if anybody has any questions about things so far. We're going to have time at the end as well. So think of yourself now in that bystander thing. You are in a milieu and you hear some of that either very overt disrespect, or you realize this is part of this micro invalidation, microaggression kind of stuff. Why do you think people don't speak out when they see that? We're still getting into some funky statistics here. Not adding up to 100, but we're getting trends anyway. Oh, thank you.
I think they're allowed to pick more than one option for this.
Yeah, that's right, Cherie. Yeah. yeah, I hadn't realized I'd done that for the second one. I know I deliberately did this for this one. Okay, so we're up to probably about the usual number who are responding. So it's really interesting. This is absolutely the number one reason across all of the departments that we've been presenting to. They have a relationship with that perpetrator, and they worry about that. And this worry about it's just going to blow it up out of the water, and it's going to be a big mess, and I don't know what to do with that. It does take energy. They don't feel it's their responsibility. For someone who wrote other, if you want to throw that in the chat, that would be really interesting as to why. Yeah. Nothing's going to change because the lack of accountability. Yeah. And, so when you say you're not a physician, two things come to mind. One is a hierarchy. The other is just, I don't know that world. I don't know how accountability would happen in the world. If it's a hierarchical thing, we need to address that as well. We need everybody working around our patients and doing the work that we do within our organization and respecting everybody having an influence within them. Okay. So I'm gonna stop screen sharing. I'm gonna let Cherie put up her slides and run her. While we're doing this flip over, does anybody have any questions? And I know we're monitoring for people who are joining us virtually as well. Any questions at this point? Yeah.
I'm not sure if you explored the impact of those comments. Let's say for medical students, is it more impactful coming from a peer like medical student or a resident or staff, or does it matter, or is it the type of comment that usually have more impact?
We didn't deliberately explore that. We didn't. My sense is that because of this perception of your faculty, like this hierarchy sort of through our learners too, your faculty are people you're going to trust and sort of just soak up their stuff. Then your senior residents, junior residents. I feel like that's kind of a level of impact, but peer-to-peer impact is important and very much there as well. It was really interesting as we were getting into this a couple of presentations ago when CARMS results were just coming out, and one of the medical students said, it's really interesting within my peers that where people matched into surgery, whatever, they were excited, they were telling everybody, and when they matched into family medicine and pediatrics, they wouldn't say anything. So the peer perception of things is impactful as well. Yeah. Okay, Cherie, I'll turn it over to you.
Okay, I can't see the room or if people have their hands up while I'm sharing. So if people want to ask questions or add anything, just a shout out would be great. So when Pinky and I started presenting our results, I would say that most groups that we spoke with, this idea of allyship was still fairly new. A lot's happened in the last 3 years, as everybody is aware of. So when I talk about allyship now, I feel like I'm often talking to a room that already knows a lot of what allyship is, what it involves. And a lot of it has come from the EDIA literature and the conversations that we've been having as a society in the last few years. But just so we're all on the same page, allyship is not just standing by and saying, yes, I think, equity is a great thing, inclusion is a great thing. It's a little bit more than that. And it's actually an active process. And an active choice, it's a choice to be always acting for those who are marginalized or don't have the power or the privilege at whatever table you're sitting at on any given day. But at the same time, it also requires you to hold yourself accountable. And this has been quite a journey for me because I can honestly say I didn't know a whole lot about what allyship was. And I certainly valued inclusion and valued equity, but I wasn't walking the walk. I was just talking the talk and barely talking the talk at that. And so I think it really becomes important to look at those biases. I mean, I think both Pinky and I started out talking about biases this morning. and what biases we bring to the presentation and the work itself. Examining some of those and examining the idea that, you know, just because I don't intend to cause harm or perpetuate the hidden curriculum, that's probably not enough to get us off the hook for not being allies if we want everything to improve and our patient care to follow suit. Oops, sorry, my slides weren't advancing there for a second. So if we stop and think about what an ally is someone who actually values equity, values inclusion, but it also means that you're committed to advancing that culture, that you're making intentional and conscious efforts to shift things and to create a new culture. And that, you know, I talk to the medical students quite a bit about professionalism, especially in first and second year. And I talk to them in their very first week in orientation, and I will tell them that they have just joined a very prestigious club. And that over the next year, even in that first year, their identity will shift, and how they feel around physicians and in the physician group will also shift. And that culture starts right from the beginning. And we all grew up in that culture. We all work in that culture. And again, speaks to the generational piece that Pinky was talking about. But it starts on day one. It probably even starts before medical school. And that culture is quite intense, and is going to be difficult to shift. But I keep telling, in these presentations, I keep telling the audiences that, you know, it's not enough just to say an inclusive work environment is what we need. We need to actually promote it. We need to be part of the solution, and we need to be making choices that are actually going to shift that culture and make it better. I also have learned from my medical students that just teaching them what to do is not necessarily enough. Sometimes we have to actually operationalize things for them and give them some ideas about how to do what we're asking them to do. And I think this is no different. So some things that I have noticed about myself that have really helped, and I've shared with others. The first is stopping to think and taking stock of where you are, challenging yourself to look at your own biases, and also be open to learning from others. And that doesn't necessarily mean that you sit down and have a conversation with everybody about this so you can learn what they're thinking or their biases, but it's just being open to thinking differently, being differently, and putting it out there. And, you know, stopping to think, do I think that there are certain specialties and areas of medicine that are lesser than my own? Or vice versa, do I think that mine is lesser than someone else's? Because it really is something that we grow up learning and internalizing, I think, and not necessarily always aware that we're doing it. And then examining our own behaviors. Again, I mentioned that, you know, we don't intentionally try to offend people for the most part. And I used to think that because I didn't actually intend it, that I couldn't, even though I still valued equity and inclusion, I could still be an ally. And I've learned, I've come to be quite humble about this, and it really doesn't matter what I intended. What matters is that it caused harm. What matters is that it actually doesn't help my colleagues to find their own power and to be able to come to the table and contribute in meaningful ways. And until we get everybody at the table with great ideas and different ways of thinking, we're missing out on opportunities, I think, and opportunities for success. So in order to be an ally, you actually have to know what microaggressions are and appreciate that they sneak in all the time. Have to appreciate how they actually impact our day-to-day work, how it impacts the people we work with, and then the patients that we care for. Putting yourself out there as being somebody who actually openly values a welcoming culture, a culture of civility, is one thing you can do. I think one of the things when I first started this work that I noticed is that this is such a huge problem, and as Pinky correctly said, it's a very wicked problem. So it's going to be very difficult to shift the culture. It's going to be very difficult to make this better. But and we all have different styles of how we operate and interact with other people. Some of us are very much geared towards the organization and the system issues. I can't say that I'm one of those people. Some people are more geared towards making their small baby steps quietly in their own personal lives, in encounters with their colleagues one at a time. And I don't think the call is to actually be active in all levels of trying to shift the culture. I think it's about finding a way to be part of the solution. And so personalizing it and finding a way that you can contribute to shifting the culture is really important. And there's lots of ways to do that. We all have reputations. Our students and our colleagues, when our names come up, they have a certain idea of what we represent, what we value. And sometimes on some days, it might be just all you can do to put yourself out there as being civil and modeling civility so that your learners and your colleagues can witness that and then come to value it as well. Listen and validating colleagues from marginalized areas of medicine is another way that you can shift the culture. Again, it's one-on-one quite often. But I think too, sometimes when we are spoken to about maybe the transgressions or microaggressions we may have perpetrated, especially when they're unintentional, which is what microaggressions are. When somebody calls us out on it, we tend to get defensive and say, "Oh, I didn't mean it. Oh, that's not what I meant to say." And instead, take the time to step back and listen to what they're saying, because it'll give you some insight into how their marginalization is impacting the work and the morale of the group that you work with. So that might be another way that you might intervene. And we talk about privilege, and we hear about the word privilege all the time now, but it's really just recognizing that you, at certain times of the day, at certain tables and committees that you might sit on, or in certain environments, that you have an opportunity to speak up where others don't. And if at those times you actually are modeling civility and embracing inclusivity, that's going to come across. And those are the really powerful situations where you can intervene, contribute, and really demonstrate that you value this and that you're part of the solution, and begin to walk the walk. So the last part of the presentation I want to go through is a couple of examples. And if anything, I think the most important thing to walk away from today is the idea of our own personal biases. That being part of the solution doesn't mean fixing the problem from the bottom to the top and the top back down to the bottom. That there are little ways that you can do it and be part of the solution. And I guess, we all have days that are harder than others. Post-call for me, those days are harder for me to try and commit to things that I want to do around this. But other days I have more energy and more headspace. And I think we're all pretty much like that. So the idea is to do what you can when you can in a meaningful way. So this is a scenario that I've made it up, but it basically does come from some of the narrative comments we received from students and residents and even faculty. So you're sitting at the nursing station finishing your rounds for the day, and you overhear a conversation between one of your colleagues and a medical student. The student has just expressed her interest in surgery as a potential career option, and your colleague recommends she pursue family medicine instead because she's a woman. This is age old. I heard this when I was a medical student. I have heard this from residents and medical students ever since I arrived at Queen's 20 years ago, and continue to hear it on a day-to-day basis as in my role as Assistant Dean of Academic Affairs, when students come and tell me that, this is a form of mistreatment and this is not okay. So one way you might actually respond is that you interject into the conversation that the student might be interested in meeting with one of the female surgeons in the department for another perspective. Something like, Dr. A, why don't you email Dr. Z and let her know about your medical student who's interested in becoming a surgeon? I'm pretty sure Dr. Z would be delighted to share what it's been like for her training and working as a surgeon. So it's not confrontational. It's a suggestion. It's not calling out the person, but it is actually working on the potential harm that the comment that your colleague made. So calling it out might be one way to shift the culture, but minimizing the harm and the impact on our learner is an equally suitable option, I think. Another, in the OR lounge, you hear one of the anesthesiologists tell a medical student that they would be a good fit for a career in family medicine or pediatrics because they have a, quote, nice personality. That someone with a, quote, nice personality would not do well in a surgical specialty. So if you do have the energy or you have the comfort level to be able to confront or call out a colleague, you don't have to do it in a really negative way. You can actually do it as, tell me what you were thinking in that situation when you said, I'm curious, I'm interested in your perspective. And you can just say, when the student's not around and has gone off to do their work for the day, ask your colleague, what did you mean by a nice personality being suited to a career in a non-surgical specialty? Try and getting the discussion open. Make it about educating or challenging those biases that somebody has that they may not recognize. But again, making it about a collegial discussion and from the point of curiosity as opposed to the point of trying to correct directly. And then this one, I will say I fell victim to this one as a resident, full disclosure. At coffee, you and several of your colleagues are chatting and the conversation turns to exchanging war stories from your recent nights on call and the quote unquote ludicrous consults you've had to deal with from the ER. One of your colleagues makes a disparaging remark that ER docs are just glorified triage brokers who want the specialists to do the hard work of assessing the patients. So I will share that I actually was, as a resident, sitting having coffee one morning, and one of our attendings was with us, who would often join us. And this was the conversation at the table, and he very pointedly called us all out. And I'll share the gist of what he said that morning. He called out the inappropriateness, as I said, but he also pointed out that part of being a really competent ER doc is recognizing when specialty intervention is required, and it's in the best interest of the patient. ER physicians take triaging and gatekeeping of our system very seriously. It's a skill set that they have and that they learn through their residency. And in actual fact, doing what we were complaining about was the sign of competence and skill in their profession. So I ate a bit of humble pie for sure, but I think that's another way to kind of call it out in a conversation where not one particular person gets all the feedback, but just again putting out a contrary view to maybe what's being discussed, and maybe it opens it up to a bigger conversation, or it just means that a eureka light bulb comes on for some of the people in the group. So I'm going to finish here, and I'm going to stop sharing. Because the discussion is the most interesting part of this, I think, for Pinky and myself. If I don't get a chance to, because we run out of time, I do want to say thank you for the opportunity this morning. We've been doing a lot of these presentations in the last 3 years, and I think we can almost do them verbatim from one to another, but the comments in the discussion is always unique. So I'm very keen to hear what people are thinking and have to say. Thank you.
Perfect. Okay, so with that, I know it's, what are we at? We're at about 10 to 9. Does anybody have any thoughts about either the result that we talked to you about what they've experienced and ideas? So Mike, I see your hand. Do I see you?
Good morning. I'm trying to make myself visible here.
All right.
Morning.
Hi guys, thank you. That was fantastic. Thank you so much. I'm sitting here thinking about the pathology of this and reflecting on Pinky's comment that not much has changed since we were both in medical school. And I'm wondering how much is known about the psychology of this. Are these things learned behaviors that are passed down from generation and can be unlearned? Or are they fundamental traits of personalities that are attracted to medical school, maybe some particular specialties, and the best strategy is to mitigate the damage rather than actually trying to change their behavior, which is unlikely to be successful if that's the problem. What do we know about what's most broken here?
Yeah, so Mike, as is usual, you've hit on in that about 6 really interesting ideas. So certainly the thought about who do we admit into medical school, what kind of traits are we looking for? I think that's a whole realm, you know, and is there a better way to both articulate what we want in our future healthcare practitioners and then select for that, you know? So are those situational judgment tests? How do we align the selection with the traits? And it goes to sort of first outlining the traits and then trying to figure out how best to do it. I feel that we truly influence people though through their medical school career. So one of the quotes that to me just resonated was a medical student saying, I didn't come into medical school thinking generalist areas of medicine were lesser areas of medicine, but I'm leaving it with that thought. And so what do we do to people to change their perception through their medical school career? But I also believe there is some psychology, you know, so those 2 points of why does the need to be part of a team devolve into hierarchy with better and lesser, like, because it happens all over the place. It's not just in medicine. It is kind of a universal thing that where there's this need for hierarchy, need for structure. Why do we have that? So we absolutely have talked about having a psychologist on our team to start to unpack some of those fundamental psychological needs, and then think about how do we change how that gets expressed, or what we value, or what are the way that we act. But then our approach is realizing there will be some people you won't change. So we're hoping the education will, because people in fact are well-meaning, and if they realize what they're doing is having a negative impact, they'll work to change their behavior. So we really hope the education piece is going to work. But that's why we also have built in this remediation and then hold accountable piece to it, because we realize it won't always work. Cherie, was there anything more you wanted to add?
Yeah, no, Dr. Brundage, is very dangerous for a psychiatrist to use the word personality and psychology in the same sentence and not expect an hour-long diatribe from one. But I will say that I agree with Pinky. There are some people where the personality is the issue, and those are, you know, in other areas we would talk about the disruptive physician, for example. And there is research to show that some of those people come into medical school already with that personality hierarchy that's going to cause those kinds of problems, and not going to be terribly amenable to shifting, recognizing their behaviors, recognizing the need to change their behaviors, and then actually making the changes. It's part of that personality set that they have been born with. But I think, you know, we had a lot of conversation when we first started this working group about when does this start, and I think a lot of it actually starts before our students come to medical school. There is no doubt that we build this culture and we purvey this culture to our students throughout their training from very early on. But you know, if you think about, Pinky disclosed she was you know, in medical school in the 80s. Well, I was in medical school in the 90s when ER was huge. And if you look at all those medical shows, there's a new one every 5 or 6 years that replaces the old one that's not being watched anymore. And what's seen in those shows are those high intensity, high adrenaline, exciting kinds of things. They're not necessarily seeing, you know, what we do day to day, whether we are psychiatrists, family docs, or specialists. They're seeing that high glamour stuff. So I think that right from the beginning, the way that medicine is portrayed to our students and to society in general already sets it up. as there are some things in medicine that are definitely more exciting and more valued and more attractive. So
Right.
I think it's a big issue and a big problem, but I think we also as human beings, I think we need to know that we're perceived by our peers as being positive. And again, I think how we think about ourselves and what other people think of us figures into this as well.
Thank you both for taking this on and for sharing it with us.
Thank you.
Yeah, and we do have this great implementation team that's now working on the recommendations from the working group and really trying to think of it in this very broad way, Mike, to kind of think about the various different ways this gets either inculcated or perpetuated. Hi, Martin.
Hi, Pinky. Can you guys hear me okay?
Yep.
Yeah,
Morning.
it's great.
Oh, thank you for a lovely talk. Really enjoyed listening to both of you speak about this. Just one comment, I recently saw an example of a medical student rotating through our specialty, and when I asked what they're interested in, and they kind of put their head down and said family medicine. It was very, very tough to actually see. I hope I turned it into a positive learning experience by saying, oh, great, you're going to be seeing lots of oncology, so maybe we can focus, some of the teaching towards your personal goals. I guess I have two questions about, stemming around this artificial hierarchy that seems to be, pervasive in our culture. One, I was curious, the impact, I guess, of human nature, and that we always seem to want what we can't have, and the CARMS process, I think is a great example of, the stress and this idea that, some specialties are, from year to year, just more competitive for reasons that I'm not sure I completely understand. And, is there an implicit value that we start to attribute by thinking, this is more competitive, therefore it's better? Is sort of one question. And the other is, we've been having a lot of discussions at the OMA level about, physician compensation. And, there are some huge discrepancies in financial remuneration amongst specialties. And, is there a value judgment that, seems to be attributed to that has also made its way into the hidden curriculum?
Yeah. So I'll start from where you ended and sort of go backwards. Absolutely, pay is equated with value, and our fee schedule is very much procedurally driven. Procedures are compensated relatively considerably higher than other areas of medicine, and so thinking about how do we start to address this at that macro level, that organizational level, for sure, that there's a small little thing we'll try and change, but it's an important thing because it does drive things. And I think you're absolutely right also around the competitiveness, that the harder it is to get, the better it is. We tend to be a relatively competitive group in medicine. We've been high performers, and so it starts to drive a little bit of that. So I believe that as well. But the other thing I want to do is I want to applaud you for what you did with that learner, because I think our central message is it's the patient and then the learners who are in the middle of all of this. And what's great care for a patient is trying to figure out that smoothing that transition from, in this example, family medicine to oncology. So what does the family physician do well to get things set up and ask the right questions and to you as our specialist colleagues? And then when the patient transitions back into the care of the family physician, what do we do to smooth that? So I love that idea of being learner-centered, figuring out, what's going to actually make this person be the most competent person they can be in their area of choice. All choices should be being considered to be equal. How do I contribute to that? I love that.
Big shout out, Martin, for doing, so that's a really good example about how one person can make a difference to a medical student. It doesn't have to be confrontational, but it actually sends a message and it puts you out there as somebody who is not willing to perpetuate that hidden curriculum, but also not have it impact on a student's trajectory. Our students are very, very easy to sculpt, and they're very impressionable. And I think we really forget sometimes how even the littlest things that we do can have lasting impacts. And that's for good things just as much as it is for negative things. So I think that's a brilliant way and a really great example of how we can have some power and shift without making it an exhausting process.
Do we have time for one? I'd really love to. No? Yeah, I'd love to hear your question or comment.
Thank you. This is a great presentation. My comment is about the concept of safety, which a lot of people who are not minorities don't have to deal with. And also because I think it would be good to add that
Yes.
to your the reason why you don't want to come forward.
Yes.
So I think that's the important concept to add. And then the other thing is the concept of hardship. I would like to be a little bit taken a step back. For example, the dismissal and defensiveness. I think that's a higher step when someone comes and complains to you about what you did to them or tells you what you did to them. Even hearing it from people who have been microaggression directed to them, and if you tell it to colleagues or if you tell it, there is sometimes this uncomfortable silence or the dismissal or the principle. Also, someone has had a bad day that day. So I think this is important to people actually before, even it's not just we're not even at that level where we're even at the more basic level that needs to be considered.
Yeah, those are really important comments. And I think we need to make it more explicit, the two things you've just said, because when Cherie is talking about, we all have our different ways of feeling like we can be part of the solution, and safety ties into that a little bit, but it's a distinct thing unto itself that we need to be more explicit about. And then your second comment around dismissal and just silence and the impact of that would be great actually to chat more, because we're continuing to work on this. So, we're building educational opportunities and thinking about, so there was a simulation, train the trainer, bystander allyship course, and how I want to get this into the hands of actually every resident, every faculty person about being a helpful bystander and being an ally. And so the conversation would be great to continue. I know we're running over time. I don't mean to do that. I'm sorry, but thank you everybody for being here, for listening to us, hopefully taking something away from this, hopefully thinking about how you might move forward yourselves. And the conversation has been really great. Thank you so much.
Thanks, everyone. Have a good day.
Thank you.